Hello, I'm Dr. Robert Lelouch, a board-certified OBGYN physician with over 30 years of clinical experience. Today we're going to talk about heavier periods in your 40s and what can be done with it. This is just some general information. You certainly need to see your physician to get it handled and to see what your particular problem is and what the solutions are. But oftentimes, without any other specific finding, we have two important interventions that are highly successful at treating your heavy periods. One of them is called thermal ablation or endometrial ablation, and the other is progesterone-containing IUD. So we'll be emphasizing those two options, which often turn out to be available to you to solve your problem, and both have some risks and benefits. So that's what we're going to go over. So when you see your physician, you're going to have an exam and an assessment to see what is the cause of your bleeding. A common cause of bleeding is fibroids, which are non-cancerous tumors of the uterus most of the time, that 70% of women have by the age of 50, but they start appearing in the 40s. And depending on their locations, they may or may not be contributing to your bleeding. But assuming you have an ultrasound that shows no fibroids, you may also have something called a polyp, which is a growth inside the uterus or inside the cervix. Again, very rarely is it cancerous, usually not cancerous, and that would require a removal of the polyp or a D&C or something called a hysteroscopy, where we look inside your uterus with a camera and remove that. So, barring those, the most common reason is simply labeled premenopausal menorrhagia, which is heavy periods before menopause, and it's very common in the 40s, especially between 45 and 50. I would say I have at least 5 patients a month with this condition. So you might be a candidate for some medications, for example, the birth control pill, but there are many reasons where you might not be able to be eligible for that. For example, if you're a smoker over 35, you can't have that. So it will come down to frequently that the best choices are the endometrial thermal ablation. I do the procedure called the NovaSure ablation, or the IUD. I use the Mirena IUD. There are other progesterone-containing IUDs. They both have a good success rate at reducing your periods. So let's talk about the IUD first. The IUD doesn't require surgery. It's in the office. It's very easy and convenient, and it's lower cost for most patients. Depends on your insurance. It doesn't require going to the operating room. It can be done in the office. It lasts 7 years, and depends on the type that you have, but the Mirena IUD lasts 7 years, and it has been shown by studies to reduce your bleeding by 80% within 3 months and by 90% in 6 months. The exact numbers might vary over time with studies, but it's pretty successful. Very safe, very effective. There are small risks with the IUD. Your physician will give you more information, but I find that some of the risks, for example, perforation or malpositions, are pretty darn rare, especially perforation. So overall, very safe and effective procedure. The other alternative is the endometrial ablation. That is a procedure where normally we do a hysteroscopy first. It is a surgery. You are asleep for a few minutes and look inside with a camera to see that there's nothing inside your uterus. Then we do a D&C, scrape out the lining of the uterus, and then we put the device inside the uterus that basically destroys the endometrium, the lining of the uterus. So your hormones come from your ovaries, and they thicken the lining of the uterus in preparation for pregnancy. That thickened lining is a rich garden for the egg to implant in, and when there is no pregnancy, that's your period. That's what comes out. It's more than just blood, it's the lining shedding. So when you get the endometrial ablation, we're actually ablating or destroying that tissue. The device I use is called the NovaSure device, and it uses radiofrequency ablation, which just basically heats up and destroys the lining. So there's no tissue to respond to the hormones that come from your ovaries. So you still have the hormones from your ovaries, it just eliminates the tissue. And that the overall success rate is approximately 95% of women have improvement in their periods, and approximately 70% have no further bleeding. Very low risk, but there are risks, like all surgeries, a risk of bleeding, which we're treating you for, infection that can happen, delay your recovery, need some antibiotics, risk of injury to adjacent organs. That means when you put sharp instruments near the human body, there's a chance that something will get cut or injured. It means doctors are human, errors occur. In the case of the NovaSure device, there is a safety mechanism to first ensure that there's no injury to the uterus or hole in the uterus, where we inject some CO2, some air inside the uterus to make sure it's intact and hasn't been perforated, to avoid injuries and really enhance the safety of that procedure. There is a small number of patients, less than 1%, but that number may vary, and again, get this information from your physician, that have decreased bleeding but increased cramping, and some have something called post-ablation syndrome, where they have significant cramping, where a little bit of that tissue is left and still responds to hormones, but because the rest is destroyed, it causes a backup of pressure and a significant amount of bleeding, significant amount of cramping, and that sometimes necessitates a hysterectomy. So overall, they're both pretty similar in their success rate, but the ablation, once you've done it, you're done. There is each has a small chance of recurrence of problems or being unsuccessful. A recent study suggested a little higher chance with the IUD of later going on to needing further interventions, including hysterectomy. Either one can have that intervention, but a general rule of thumb in medicine is we try to do the smallest intervention possible to solve the problem. And that's why these are often better than resorting to a much more invasive procedure like a hysterectomy. So again, this is just general information. I don't know the specifics of your medical history. It gives you a base of education so that if you're confronted with this problem, you're armed with some information when you go see your physician, or after you've discussed it with them, and can ask better questions to get a tailored answer for your particular situation from your providing physician. I hope you found this helpful.